Ladies and gentlemen, we are pleased to welcome to the stage the new president of ASCP, Dr. Stephen Croft.
Good morning, and thank you very much. Welcome to day 3 of ASCP 2013 in Chicago. I hope you're getting around to as many educational sessions as you can and you find them informative and energizing and exciting. ASCP is honored, to present this morning's general session in partnership with our partner, the Association for Pathology Informatics. For decades, the field of pathology informatics has enjoyed relative tranquility. Yet today, this field is playing an increasingly and expandingly significant role in pathology and laboratory medicine. Scientific discoveries in genomics, health system leadership focus on enterprise-wide IT solutions and EHRs, as opposed to best-of-breed ancillary systems, confusion in the digital pathology market caused in part by regulatory pressures, and cost containment pressures associated with the Affordable Care Act are among the many factors fueling this expanded interest. Our presenters for this session are pioneers in this field and will help us navigate the many stumbling blocks that we all face, as well as help us to unlock the many benefits this tool can provide toward improving the delivery of quality patient care. Please join me in welcoming our moderator, Dr. Mark Tuthill. Dr. Tuthill is Division Head of Pathology Informatics at the Henry Ford Health System and also a leader in the Association for Pathology Informatics. Dr. Tuthill.
Thank you, Jim. Appreciate it. Good morning, everybody. How's everybody doing out there? Everybody holding up? What a feast this is, huh? Well, I'm very excited this morning to be able to welcome you to the first collaboration of the Association of Pathology Informatics with the American Society of Clinical Pathologists. And it's my honor to introduce our speakers this morning. Before I go there, I want to actually introduce some students that we have with us. We have 600 students from the Perspectives ITT Math and Science Charter School in Chicago. All right, I hear the students out there. Could I get you students to all stand up for a moment so we can see in person? Yeah, let's give them all a big ASCP round of applause. All right. Well, my teleprompting's not working, so I'm on the ad lib, but that's usually what I do anyway. So this morning, I'm going to actually begin to introduce our speakers. But first, I wanted to give our students a little bit of a perspective on what pathology is. Pathology is a science that is responsible for classification, diagnosing disease, so that we can figure out how to treat it in medicine. We use all sorts of tools to do this. We use microscopes, we use computers, we use powerful instruments, and there is a lot of math involved, engineering and science. So this is really important for the students to understand. Pathology informatics is how we analyze, store, and manage all that information that we gather from these powerful tools. Now, interestingly, in the 20th century, information technology in the laboratory transformed the way we did our work. But in the 21st century, it is a basic requirement. It is a foundational requirement for the laboratory even to function. Today, I'm going to introduce to you two of the thought leaders in pathology informatics who specialize in pathology informatics, Dr. Bruce Friedman and Dr. Ulysses Balis, both of whom are from the University of Michigan. Together, they're going to paint for you a picture of the opportunities as well as the threats that are facing us and our ability to serve our patients effectively because of the complex problems that we have in our healthcare system and the incursion of information technology at the enterprise level. Our first speaker is Dr. Bruce Friedman, Professor Emeritus at the University of Michigan. I've known Dr. Friedman for a long time, and interestingly, he is credited with introducing the term pathology informatics into the lexicon. I'm sure Dr. Friedman is beginning to regret this, especially since he's had to deal with me as a mentee for a number of years now, so I can say that very honestly. But seriously, Dr. Friedman has been tremendously influential in the field and has been a mentor to many of the people who have practiced pathology informatics. So without further ado, let me please introduce my friend and mentor, Dr. Bruce Friedman.
I feel like a rock star. This is fantastic. My talk today will be a little bit controversial, but relatively simple compared to Tuthill's presentation, which is much more complex. But it's a pleasure to share the podium with both Mark, who was our first virtual fellow in informatics, and Ulysses Balis, who replaced me as Director of Pathology Informatics at the University of Michigan Department of Pathology. So my talk is preparing for seismic shifts in pathology informatics. Here's my disclosure of conflicts. I'm a consultant to the Association for Pathology Informatics, which is a nonprofit medical society. And there's another relationship that has a somewhat of a commercial feel to it. I've been told that Epic may have put a price on my head. That's not clear yet. Wait till I get through the lecture. So there's a number of significant forces now combining to create a major inflection point. That was my reference to the tectonic shifts. The first 2 points are the most significant. And what I'm going to do is go over the sort of gist of my talk very briefly, and then I'll go through the points later on. I think we're at a very major juncture right now due to the wider adoption of EHRs, or electronic health records, and what we'll call enterprise-wide solutions. I'm going to be picking on Epic. Epic is what I'll call the poster child for enterprise-wide solutions at the present time. Another company that would fall into this category would be Cerner. But Cerner has a best-of-breed LIS. Cerner started as an LIS vendor. Epic provides an LIS which is relatively immature, called Beaker. And part of the problem, and I'll be discussing this at greater length, is that Beaker is a relatively immature LIS, and I'll be referring to it as a good enough system. But we can't tolerate good enough systems in pathology, and I'll be discussing how the functionality of the LIS is absolutely critical for the job that we do and provide for the patients in our hospitals. This problem is exacerbated by hospital cost containment, which you're all familiar with. And this is causing a squeeze on the pathology and the lab budgets. So what are the problems associated with a good enough LIS, such as Beaker, which in time may in fact become a best-of-breed system, and best-of-breed is a term that I'll be using as well in the talk. Many hospitals are being forced to install Beaker as part of an enterprise-wide solution. And there is the incorrect notion that Beaker is free. In fact, Beaker is not free. A hospital may sign a contract such that the licensing fees for Beaker are covered, but there still remain installation fees for Beaker, which can range for a medium-sized hospital from something like $800,000 to $1.2 million. So Beaker's not free. In addition, there are functionality gaps, and we'll be talking later about functionality gaps in this system. There are functionality gaps which must be plugged in order to have a fully functioning LIS. And there's a cost for these additional modules. So in fact, Beaker may end up costing more than a best-of-breed system. I was at the Sunquest user group meeting several weeks ago, and the CIO from Intermountain Health System, Mark Probst, was talking about enterprise-wide systems and EHRs. And he said, in many cases, they're quite inadequate and a problem. In fact, Mike Bisich said yesterday that EHRs don't work. So I put to Mark, the CIO, I said, what's the end game with some of these monolithic systems where it's the only major system running in a hospital? And he said, I think that the end game is meltdown. So I pushed him from a definition of that, and in my mind, I see two versions of EHR meltdown. One is a slow motion meltdown, where some hospitals that are installing Epic and Beaker are having financial problems. We'll talk more about that later. And then an acute meltdown. And Sutter Health System experienced last Monday a total down of the system for about 4 or 5 hospitals. A spokesperson for Sutter Health said the system was live, but no one could access it, which I think is splitting hairs. There were no meds distributed for 12 hours. So you have that kind of, apparently it was, there's a rumor that it was a problem with Citrix, but the point is, the Pyxis systems were interfaced to the system, no meds were passed from the morning to I think the early evening. So this is an example of an acute meltdown. So I'll go into more details about this, but I think we're facing a serious problem, but I have a solution, or we have a solution. The Association for Pathology Informatics has come up with a solution, and I'll detail it later in the talk. So for the sake of completeness, I want to just quickly point out 2 other challenges that pathology informatics is experiencing. One is a transformation of pathology and lab medicine by major scientific discoveries. I only need to say to you genomics and proteomics, which will place great demands on our IT, and therefore we need cutting-edge IT. Mike Bisich spoke yesterday about big data. His talk was absolutely outstanding, and he went into great details about the technical and scientific challenges facing us. And finally, for the sake of completeness, I won't return to this. There's confusion in the digital pathology market due to regulatory issues. So that's not maturing as fast as it might. So this is the general outline. This is where I'm headed. I'm going to first discuss the criticality of LIS functionality. This word will come up frequently in my talk. Functionality is what the system does for us, the work that the system does. I gave you a hint of this second point. I'll show how the emerging dominance of EHRs and enterprise-wide solutions threaten the optimization of LIS functionality. I view this as an existential threat to pathology informatics, and I'll go into more detail about that. I want to place EHR deployments into the context of hospital organizational settings and goals of executive officers. One of my colleagues asked me a few years ago how I got into pathology informatics. And this is a similar story a story similar to what other people talk about. My chairman called me into his office in early 1982, and he said that the director of pathology informatics was leaving, and he asked me to take the position on an interim basis, and then he said, until we can find someone qualified to do the job. He was right. I had no background in computers, but I stayed in that position from 1982 until I retired in 2006. And I was never outstanding in terms of technical issues, but what I was pretty good at was hospital politics. And 2/3 of my job was political. And by politics, I mean competition for resources. And what I'm going to be discussing today, the growing threat of EHRs to pathology informatics, is basically a political problem and one related to competition for resources. So we'll talk about hospital organizations. Then I will explain how to develop a more data-driven relationship. This is my solution. This is what I'm going to say to you, is these changes are not inexorable. You can change this drift toward these total dominance of EHRs. And finally, I will show what I call LIS functionality zones. as a basis for the strategy, and I'll present an action plan to ensure the future of pathology informatics. I'll be using two key terms in this lecture. The first is a mouthful, TLISF, which stands for Total LIS Functionality, and then we'll talk about what's a best-of-breed LIS. TLISF, or Total LIS Functionality, includes the functions of the classic LIS, plus other types of software that run on our labs, middleware, outreach support, and firmware, which is integral to all automated analyzers in the lab. Without the LIS, and you all know this, I'll just make the point quickly. Without the LIS, all clinical and hematopathology, histopathology labs would abruptly cease working. And those of you who have experienced downs of your LIS know that not much work gets done. So the LIS is absolutely critical for the work that we do every day. And I won't repeat how important lab data is to the care of patients. Now, because of the heterogeneity of all this software, the integration of all these systems can be challenging. And in fact, that's the advantage. That's why CIOs like an enterprise-wide solution, because the integration is shrink-wrapped. However, what we end up with is a monolithic system, and the meltdowns that I referred to, which are going to become much more frequent as we go forward. So I'm a great advocate of heterogeneity and multiple systems, particularly LIS and in radiology and other departments. You all know what best of breed means. It's superior functionality and price in a head-to-head competition. And you know the best of breed LISs as opposed to some of the newer systems like Beaker, which is what I will refer to as good enough. And I will tell you here that we cannot tolerate good enough systems in the laboratories. So the major goals, and you all know this, the major goals for us, pathologists and lab professionals, is to optimize LIS functionality. We want to report test results as accurately, quickly, and efficiently as possible. We're often judged on the average cost per test. That is the metric commonly used by the C-suite to judge our performance. So the way you keep hammering down that cost per test is through automation and through LIS functionality. And LIS functionality is a major contributing factor to these goals. A second component, obviously, is professional competence. Optimization of total LIS functionality usually results in superior job performance. Hence, this is also defined as a major goal, in addition to professional competence. Now, this is the key bullet point on this slide. Total LIS functionality is primarily understood and optimized by lab professionals. One needs an understanding of the mission and the workflow of the laboratories. Therefore, the CIO cannot and should not define for you what is an optimal LIS and what is optimal LIS functionality. So how have we gotten into this position where the EHR and enterprise-wide solutions are so dominant? And we convened a conference last spring in Pittsburgh, and the focus of that conference was to discuss this dominance of EHRs, whereas we've had a history of 30 years of tremendous success with best-of-breed LISs. And the beauty of our environment, and the beauty of what we created, is we had the relationship with the LIS vendor. If we needed new functionality, we would pick up the phone and talk to the vendor. With an enterprise-wide solution, the power curve is moving to the C-suite, and the total system is picked by the hospital executive officers with very little input from pathology. So we've moved from a system where we could optimize the LIS, have a relationship with the vendor, to a point where we have to stand in a queue if we want more functionality of our LIS, and that will affect our performance. The reason that the EHRs have become so dominant is because they meet an important need of the executive officers of our hospitals. The enterprise-wide system and enterprise-wide solution vendors assume responsibility for what I call shrink-wrap system integration. In other words, the integration occurs at the level of the vendor and then is installed. And this is relates to this monolithic nature that I talked about before. And the enterprise-wide vendors offer an array of what I call embedded systems, such as LIS, Radiology Information System, Pharmacy, OR, Emergency Department. And of course, Beaker would fall into this category. Now, I'll make a statement that sounds sort of didactic. You may or may not agree with this, but I believe it's impossible for all of these modules to obtain best-of-breed status. Now, I'm sure it's Epic's goal to convert Beaker into a best-of-breed system, but I believe that the current market conditions allow good enough status for many of them. And are we going to tolerate a good enough LIS to run our laboratories? Now, along with this dominance of enterprise-wide solutions is the growing importance of hospital CIOs and the central IT groups. And I know something about this because for 5 years at Michigan, before I retired, I was an IT director reporting in part to the CIO as well as to the chairman of pathology. So I know what goes around, what's discussed around these tables. And I know the concerns of the central IT group. The CIO and the central IT group select, contract for, and manage the relationship with the vendor. The lab wish list for new LIS functionalities gets filtered through multiple layers. And in fact, a company like Epic delivers features to the hospital largely decided by them with some input from the hospitals. This is far different than pathology's relationship with best-of-breed LIS vendors in the past, much less collaborative and much less participatory. And I know this can be somewhat controversial, but I believe that the goals of the CIO and the central IT group differ from those of the clinical labs to a certain extent. Hospitals, in general, tend to be somewhat inward-looking. They optimize patient care and experience and delivery of quality of care. Labs and pathologists have always been more outward-looking. For example, we send specimens to esoteric reference labs and get input from outside consultants. Particularly in an era of cost containment that we're in now, the central IT group will seek to reduce FTEs, and they do this by standardizing and reducing the need for integration, hence the popularity of enterprise-wide solutions. So the central IT group has incentives to trade functionality within individual departments, read pathology or radiology, for a perceived good of the whole. And you may hear this phrase coming up periodically. This approach often results in bad outcomes for pathology in the labs because the labs will always be judged in terms of their efficiency and cost per test. So what motivates hospital executives and why are they willing to risk lower functionality? For one thing, they don't really understand what happens at ground level in the laboratories. But hospital executives are motivated by the following three things, in my opinion: to optimize financial performance, to reduce risk, and Me Tooism. And I think the increasing popularity of Epic is in part based on their successful deployment of their systems, whereas in previous years, EMRs were not always successful in going live. So when you interact with executives, I think you need to always couch your arguments in terms of financial terms. My experience has been hospital executives will discuss quality, but generally they won't fund pure quality projects. And given the enterprise-wide model of one price for all software, executives will often consider a module like Beaker as a free lunch, but as I said before, in fact, it is not free, and in fact may cost much more than a best-of-breed system. So the only way to counter these arguments in highlighting software functionality gaps is through numerical data which you need to present to your executives, including a total cost of ownership worksheet that would show functionality gaps and the cost of plugging these gaps. So what I'm talking about here is the need to create a data-driven relationship with the C-suite, combined with a new master IT strategy, and this is where I'm headed. So the first step is to cultivate a relationship with the hospital executives. This may not be easy, but one thing you can do is create an alliance with the chief medical officer and emphasize how critical the performance of the labs are for the satisfaction of the clinicians in the hospital. So the key elements in these discussions is avoiding, in my opinion, the installation of a good enough LIS solely based on the hospital march toward an enterprise-wide solution. A good enough LIS may cost the same or even more than a best-of-breed system. A good enough LIS may have functionality gaps, and where I'm headed is to provide you with a tool for focusing on and showing what these functionality gaps are in a good enough system. And a good enough LIS may impair lab services and alienate hospital clinicians. So I'm pleased to announce today for the first time the availability of what we're calling an LAS functionality assessment toolkit. And the purpose and the goal of this toolkit is to give you something to work with in terms of defining functionality gaps in a good enough LIS and the cost of filling or plugging those gaps. This toolkit that we call LIS-FAT for LIS Functionality Assessment Toolkit is provided to you free of charge by the Association for Pathology Informatics. We've been working on this for 6 or 7 months, and this is a result of a strategic summit that we held in Pittsburgh last spring. There are 4 parts to this toolkit, and it's available at the API website. The first is a 6,000-word white paper, which provides a rationale for evaluating the functionality of an LIS, particularly a proffered good enough one. An appendix, and here's the key document in this toolkit. It's a list of 850 functionality statements covering all of the various functions of an LIS, and it's useful for highlighting the functionality gaps. These 850 statements are weighted 1 through 4, with the 3 and 4 statements are the key ones. And this whole project was put together by Andy Splitz, Ulysses Balis, Mark Tuthill, and myself. Appendix 2 is a set of scenarios which you can use for a guided live demo if there's a demo of the LIS in your hospital. And finally, an Appendix 3, which shows elements to include in a total cost of ownership worksheet. It's a way to calculate the costs of functionality gaps. Now, this seems kind of overpowering, but I believe that this toolkit will take on the trappings of a quasi-standard as to the functionality of LISs and a way of illustrating gaps. And I've been speaking to some of the best-of-breed LIS vendors, and they're delighted to have a tool like this available so they can prove to you the high level of functionality of their systems. This is now available. It was put on our API website, and here's the URL. And just remember Pathology Informatics, www.pathologyinformatics.org. It's free. You do not need to be an API member to download it, but we encourage you to support the API through your membership and to express your support for these kinds of projects. Now, I want to wind up with an IT strategy if pathology is forced to accept a good enough LIS. Some of you may, in fact, there may be pressure brought to you to install a good enough LIS. In other words, reality dictates that some of you may have an LIS like Beaker or may be forced to install it. So I'm going to present in the next slide what I call 3 functionality zones that can be used as a basis of survival with a good enough LIS. However, I want to emphasize one caveat. Many hospitals installing an EHR or an enterprise-wide solution are facing severe financial distress. An example is Maine Medical Center. They fired their CIO because they're essentially, with the installation of the EHR, they weren't billing properly with the system, and the nurses were not cooperating as they might, and the physicians were balking because their ability to deliver care was being impaired by some of the inefficient screens. So in fact, they fired the CIO and are in dire financial straits, at least short term. So there may be insufficient funds to patch the functionality gaps created by installing a good enough LIS. So just be aware that even though you demonstrate the gaps, there may not be capital to plug those gaps. So this then illustrates what I'm talking about, these three functionality zones. Zone 1 is what I call basic functionality. So if you have a good enough LIS, I'm told by everyone that a good enough LIS will handle basic functionality. However, an LIS like Beaker does not have a blood bank module and will probably never have a blood bank module because Epic probably doesn't want to tango with the FDA. So in fact, there are, in Zone 2, this is what I call best-of-breed functionality. That is, systems available as specialized modules or by best-of-breed vendors that you need to install and integrate in order to provide the total functionality that you're seeking. The final is Zone 3, what I call cutting-edge functionality. These are features and functions that even the best-of-breed vendors may not be adequately covering, such as genomics, proteomics, perhaps outreach. And this is the area where we're going to be spending most of our time. And you're going to have to look for solutions in this, and this then is going to place a demand on you to create greater expertise and competence in your department in pathology informatics, because these are functions which are not readily available in the market. Genomics and proteomics, most of the solutions are on the research side rather than in the service and clinical side. And this then goes over the ideas and rationale underpinning this three-zone strategy for total LIS functionality. So Zone 1, a good enough system can cover it. Zone 2, you may need to look to other vendors and integrate those modules in the standard way with interfaces. And Zone 3 is areas where we have to be very creative. No optimal solutions. And my belief is we'll probably need to develop cloud-based solutions with major contributions from the vendors. Now, our best-of-breed LIS vendors that we've had a relationship with for 30 years cannot rest on their laurels. There are areas that they're not covering adequately. So therefore, I'm going to lay down a challenge to our best-of-breed vendors, and that is that they need to take heed of what's going on in proteomics and genomics and provide new solutions for us. And as I mentioned before, this new set of challenges and responsibilities requires talented informaticians and a much closer LIS vendor collaboration. So we're at a major inflection point for LIS in pathology informatics and what I refer to as an existential threat. So this slide goes over the challenge to our best-of-breed vendors. And it may be in response to RFPs that we may need to seek responses from two best-of-breed vendors, some of whom are better in some areas than others. The bottom line is we need the market to supply integrated quality solutions in my zones 2 and 3 that I've listed in this concentric model. And I'm not sure what arguments and forces will be necessary to drive the best-of-breed vendors to collaborate. However, I think a very positive step in this direction is our publication of the LIS functionality assessment tool, because this, for the first time, lists in very comprehensive way the functionalities that we expect from the system, and we will be publishing additional versions of this in the future, particularly with expansion of the area of molecular pathology, genomics, and proteomics. So to conclude, these are what I would call steps to ensure a bright future for pathology and pathology informatics. I've invested most of my career in this, and I am not looking forward to any diminution in the quality of the work and the information processing that occurs in our departments. First of all, you need to establish a data-driven relationship with the C-suite. This may not be easy, but you need to lobby for the need to install and maintain an LIS with maximum functionality. Second step is download our LIS functionality assessment toolkit to assess both your current and future LIS functionality and identify gaps, particularly of systems that are proffered to you that may not be good enough. Present to your C-suite the cost and consequences of installing only a good enough LIS if there's pressure from that area to install one and move in that direction. You need to increase your departmental engagement with difficult genomic and molecular IT challenges and recruit the talent that you need for solutions. And finally, increase pressure in the industry for collaborative partnerships in order to provide solutions for the most gnarly problems that we're now seeing in computing for genomics and proteomics. Thank you very much.
Thank you, Dr. Friedman, for that provocative discussion. As usual, Dr. Friedman doesn't pull punches. I have a feeling that we may be looking for a bodyguard for our dear friend. Oh, with that said, let me introduce our next speaker. Our next speaker is Dr. Ulysses Balis, who is not only a colleague, but a dear friend of mine that I've known for almost 2 decades now. Wow, time sure flies. Dr. Balis is professor of pathology. He's director of the Pathology Informatics division. He is a director of the Pathology Informatics Fellowship, all at the University of Michigan Health Systems. And interestingly, students, Dr. Balis also has a degree in computer engineering. So without any further ado, let me invite my dear friend, Dr. Ulysses Balis, to come to the stage.
Good morning. I'd like to thank Dr. Tuthill, the organizers, and the ASCP for the opportunity and privilege to be here with you this morning. In the next few minutes, I will continue on the concepts and premise that my colleague and friend, Dr. Bruce Friedman, has presented concerning these so-called seismic shifts in pathology informatics, and use also this as an opportunity to provide some maybe predictive views of where we may be headed in the not too distant future, and maybe in the intermediate term as well. And in tandem with that, to show you perhaps the view of computation from the perspective of those 2,000 years ago as a parallel story. Nothing to disclose. So as an outline, I'd like to share with you first a perspective on the contemporary view of computation through the eyes of perhaps the past and even antiquity, and then use that as a premise to showcase a number of contemporary opportunities, which are at the same time opportunities and threats, which we need to look at strategically. So changing gears very slightly, this is Europe. You'll recognize Greece and the Peloponnesus. A little bit more magnification. 2 islands in particular. This is Kythera, this is Antikythera. Relatively insignificant island in modern times, but in the past, found actually in 1900, this unusual escapement, a collection of approximately 30 or so precisely machined gears with an accuracy of 2 microns, manufactured that long ago. What was this device? It was actually a true mechanical computer. It had the ability to calculate through numerical multiplication, division, subtraction, very specific activities. We've actually found that it's much more than the 50 microns of the past, 2 to 3 microns. What was its purpose? Predicting the phase of the moon, the lunar and solar phases, and eclipse prediction. The point of all this is we are not the unique contemporary generation of computer users, certainly not within laboratory medicine or contemporary society. It turns out computers are not new. They've been around for over 2,000 years. This device was probably made in Sicily by the workshop of Pythagoras, or as you know, Pythagoras, 300 BCE. What has changed, though, is the way we use computers, which is really integral to everything we do. One of the current opportunities, as well as contemporary threat at the same time, is big data. And as you see, I'll go through this entire cycle of opportunities. Some of these terms may not be familiar to you now. They will be at the end of this presentation. What is big data? Well, it's really many things. It's a catch-all phrase. Could even be large text repositories. So big data is not specific in its definitions. Text itself can be big data if you have enough of it. Image repositories, any complex data set that has special tools or methods needed to handle properly. Certainly all the classes of omics data. Any data set that requires, because of its size, specialized storage with an internet-hosted cloud. So your data may actually exist not in one location, not in your facility, your health enterprise, but distributed in locations unknown that you may not even be aware of throughout the world. And any data set that exists as a collection of separate general types, again, distributed through a cloud. As a possible roadmap, and herein lies the problem for pathology and laboratory medicine at large, we are, of course, the purveyors and generators historically of laboratory medicine data, anatomic, surgical pathology data, cytopathology data, and now molecular data, genomics data. If we look on the continuum of types of data that can be generated and disseminated for both discovery and now more recently for diagnostics, you can see the problem is there are many, many classes of data that all are contributory to the diagnostics, prognostics, and even theranostics of a particular genome, particular patient. Each one of these disparate types of data has its necessary types of different stewardship and exchange requirements or communication requirements. These are distinct skill sets. Yet if we look in 2013 in the portfolio of curricula which we utilize to train our residents and fellows, I think we would all agree that we have a deficit in a systematic approach for conveying expertise at the informatics or data delivery vehicle for each one of these disparate systems. Yet they're all contributory to what will finally be what we call precision medicine. And that leads to the question, will or will not pathology and laboratory medicine be an integral part of this treatment data delivery pipeline, ultimately leading to better outcomes, better quality of life, better care? And so this is the challenge: to store, to generate, to process, and then to disseminate, and then to assist in the interpretation, yet another phase, of all these classes of data, which ostensibly should and hopefully will be generated by the collective pathology specialties. Or do we lose out on this opportunity and see this collection of technologies a sheet to other medical specialties who perhaps are not as well equipped or have the legacy and history of understanding how to handle large data and computer generation distribution of data? Using the University of Michigan as an example, in terms of the notion of big data, data warehousing, if there's a clinical question or a research question, often the question will begin at the clinician or the researcher, primary investigator side, which then needs to be somehow bridged to the warehouse, depending on IRBs, whether that be identified or de-identified. So requests come in, often an honest broker or ethical divide is required to maintain patient confidentiality. Every one of these modules represents a disparate and distinct type of information technology module that needs to be in place within an enterprise to make this entire data pipeline possible. And with each module is the requisite expertise. The honest broker office then manages these requests, shuttling them through its own internal set of rules in IRB to the warehouse for extraction of data. And these can be one or multiple warehouses. Again, this data warehouse is informed by the original collection of the data from patients, and that requires increasingly specific data, specific consent, which may not be present or available for historical data. An interesting twist on the ability to utilize data which we already have in our growing warehouses. That will generate then a possible collection of data, and answer to the question, which was then returned along possibly with just primary information, also tissues themselves, allowing an investigative question to be answered at the bench. And then finally leading to analytical cores that in tandem with the tissue itself can provide numerical, quantitative, qualitative results, which can go back to either the clinician for clinical management or the investigator for increased or continued discovery. And along the way, hopefully barcode tracking for minimization of errors, especially if it's a clinical care workflow, the need to have correct identification to minimize errors, reporting of very important molecular diagnostic, theranostic data for patient care. And finally, identified and de-identified data flowing back to the requester. Another dimension of big data is something we have right now with our microscopes and our whole slide imaging. If we liken the data size of a simple whole slide image scan, we see them all the time, we use them on a regular basis, maybe not universally, but they've become an integral component of daily practice. We can call that the equivalent to a football pitch, perhaps a subset field of view, quarter, and then to a blade of grass, and then finally a droplet in a blade of grass. All these length scales are present in a single whole slide image, and this represents a significant amount of information from the perspective of both data stewardship, data dissemination, and then data analysis. Most of us use whole slide imaging data at the present for the simple task of storing and then retrieving images to look at the images. Yet knowing that the information is digital provides tremendous opportunity for discovery and also for diagnostics, as I'll elaborate in a moment. So with big data as a backdrop, one immediately obvious derivative property of big data is extracting information from a collection of data that may not be immediately available or present in single granular or atomic data elements by themselves. And this leads to the topic of MAS, or multiple analytical assays. The opportunity here is to extract new and novel information from data that we are already gathering, and this data is potentially different or incremental to the obvious data of the distinct single data elements which we already gather. And I'll give a discrete example of how this might work in a clinical setting. It's also worth pointing out that at present, our LIS technology, and this underscores some of the limitations that Dr. Friedman mentioned about the 3 zones of architecture, to be able to espouse this functionality is an extension of the outer ring, the outer zone, which is the cutting edge capability. And this is exactly why it is imperative that our collective vendor resources, our collective community of LIS generation remain vibrant to be able to address these needs as new emergent properties and opportunities present themselves, such as the so-called MAS type tests. This includes structuring the capture of data within the LIS to be able to do derivative processing, to reproduce this capture across disparate LISs. Again, this is a new type of functionality that, as you'll see, requires very precise and exact implementation. With that implementation stewarded by an information scientist, a pathology information scientist, and then have constitutive input data electronically distributed from requesting laboratories to the processing laboratory. Again, an interoperability problem. And then finally, the integrated results returning back to the repositories for consumers to appropriately act on clinically. Looking at the opportunity for multiple analyte assays, there's some interesting threshold transitions that take place from a single analyte, which would not be a MAS, Chem 7. In the terms of expertise, 7 data elements is generally agreed upon in information theory to be approximately at the limit upon which a human cognitive expert can extract all the encoded data, should it be present. So this is the threshold. And so if we get to something even a little bit more, as the example will show, a comprehensive chemistry panel and a CBC, can an expert, whether that be a pathologist, an internist, for example, can that individual mine all the information which is present? And I would posit to you the answer is no. that you've actually, when you've crossed this dotted line, have entered into a realm of numerical complexity that you want to use the computer to extract more information, which is actually different than the individual constitutive single data elements. Then, as you can see, as we progress to increasingly high levels of complexity, time series data for routine studies, tissue microarrays, expression arrays, whole slide imaging data, libraries of whole slides, and then when we get into next generation sequencing and time series, and then finally population level collections of such data, you can see that the log order of complexity goes quickly until we're at 10 to the 20th data elements. Not something that we can cognitively expect to understand. Yet with appropriate use of, quote, big data and appropriate statistical methods, this data can be distilled down perhaps to something as simple as a yes or no answer. Does the patient have the risk for this entity, yes or no? And that will drive therapy, that will drive treatment, that will drive prognosis. Interestingly, the threshold for needing high performance computing somehow kicks in between 10 to the 8th and 10 to the 11th. Fortunately, it is possible now with types of computers with graphics processing units to instantiate this even on a desktop machine. So it turns out that computational throughput for many of these problems is no longer the driving rate limiting factor. It's the availability of expertise. It's the interest level and capability of the specialty to rise up to make use of this data clinically. And that is taking a long time to happen. The hope is that we can rise to the challenge before other specialties, other areas of science which are not perhaps as informed about laboratory medicine and pathology would take over this workflow and perhaps implement it with less appropriate rigor or understanding of the nuances of pre-analytical, analytical, and post-analytical. So in essence, I'm saying this should be a call to arms. We should look at big data and an exemplar such as the multi-analyte assay as something to address quickly to gain speed with understanding problems and other opportunities as they arise. For example, if we look at in the various length scales, so numerical scales of ranges of the routine analytes, you can see that if you throw all the analytes that are commonly ordered on a log scale, they have multiple ranges. Some are linear distributions, some are log linear distributions. And the patterns of disease affect all of these concurrently. It does and will take deep expertise for anybody in their training to intuitively or inherently be familiar with seeing how these patterns shift. You can see as you go from 1 to 2 to 5 to 10 to 20, being able to recognize a shift in the pattern takes more and more experience, more expertise, and this is where numerical tools become very powerful. Again, going back to this mantra of the multi-dimensional representation of data, in the setting of this larger context of personalized and precision diagnostics, this data adjacency problem becomes daunting. In other words, how do you interpret the multiple classes of data at the same time that come from disparate testing modalities? It requires, yes, deep expertise, but at some point, you exceed the cognitive capability of human interpretation. You need computational tools. Certainly, with expression array data, we already know this. No one would manually attempt to interpret this type of data. It requires computational tools, computational and statistical methods. But similarly, stepping back to the simpler example of a comprehensive chemistry and a CBC, 28 ostensible numerical analytes taken at once, it turns out that this is an exemplar for a multi-analyte assay that can predict with better accuracy than a bench-based test. So computational-based testing of 6-MP, so thiopurine therapy, which is now well established for inflammatory bowel disease, the problem being that high doses can lead to hepatotoxicity and immunosuppression, which are bad. Low doses have no efficacy. So there's the need to titrate. The gold standard, until recently, has been the idea of monitoring with a molecular-based benched assay and then adjusting dose based on results. However, if that assay has low predictive power, perhaps you wouldn't want to run the test. You might want to run the assay that would have the highest possible predictive power. And so if it turns out there's a computational solution, and there is, but it's very complex, making it difficult to implement in one location even, you wouldn't want to implement that same algorithm every single LIS in the country or world. That would be excessive effort. This points immediately and informs for the idea of cloud-based solutions, cloud-based computing, an opportunity that comes from big data leading to multi-analyte assays. I'll expand on the three things which are generated by the thiopurine testing. The primary, of course, is clinical response, and then, of course, non-adherence and shunting. Specifically in looking at the algorithm looks at the outcome of clinical response to inform and adjust dose. So the question is the patient taking the right amount, too much, or too little? The prior gold standard approach was using diagnostics which are bench-based. There's an expense associated with that, and at the same time, there's a question about efficacy. These are the analytes, conversely, which are in the routine CBC and comprehensive chemistry. You're not generating any more additional bench testing, and these tests are ordered anyway in the management of such a disorder, looking for immunosuppression, looking for suppression of the bone marrow. Obviously, the CBC would show that. And here's the interesting observation from now 4 studies that have been reproduced in Europe and the United States. This is the bench-based molecular assay. Its AUC is 0.47. For those of you familiar with ROC curves, that means that this is equivalent to a coin toss, literally. Whereas the second generation computational test has an area under the curve of 0.831, which is actually quite good. This is compelling from the perspective now that it's possible to derive more diagnostic information from the existing data that you already have in your information system. The challenge is implementing an added layer of complexity in the information system to be able to calculate so-called random forest statistics and then generate them. Shifting gears for a moment, one of the features of the Antikythera mechanism, interestingly, which was just found 2 years ago, was the Olympiad dial. As the gears progress, as an individual would crank the mechanism, it would point to one of the 4 Panhellenic games which would operate on a 4-year cycle. So one type of game every year, alternating every 4th year, with the interesting observation that whenever the Hellenic Games would commence, all wars would cease for that 1-month period. Whole slide imaging 2.0. Some brief comments. As I mentioned earlier, one of the most useful things we take advantage of whole slide imaging right now is looking at images. We store the data, we retrieve the data, and then we use it as a way of looking at the images on a monitor as opposed to through a microscope, which allows, of course, for remote presence, telepathology, remote diagnostics, frozen section support, FNA adequacy, those types of things. However, an additional data pipeline is made possible. For example, if you have an area of interest that you are interested in this case an adenocarcinoma, you could submit this region of interest to your database, extract the salient information, again, in the image space, not text, and then through some type of consolidation of the query, generate a numerical query to your database, and analysis, again, on a library of images that matches the feature of interest, and then from that matched feature, provides for you a library of matching cases to the feature you selected and what those cases were diagnosed as having. In other words, image-based decision support, or also known as content-based image retrieval. Now, if this goes well, we will switch to this machine. This is a general purpose algorithm which allows for a non-image programming subject matter expert, in other words, a pathologist, a cytopathologist, to simply input the area of interest. In this case, I have selected with this search vector the malignant epithelium. Based on this single search vector, let's get back to the right magnification. one single search vector, we can first generate matching field of all the like areas in the whole slide, which match the initial predicate. So we're basically generating a template that's saying find all the cancer. That's the first step. So we find all the cancer in this field of view. And it's not limited to cancer. As you build the libraries, you can find all the diagnostic entities and then query them against the database, which we will do in real time with this tool. So with those particular searched fields of view, we will search the image database, and immediately we have turned up other matching cases with very high confidence intervals and the image number. And then if the library has the associated metadata, the diagnostic text, for example, you have the ability now to have an image-based differential diagnosis engine. How far away is this technology from benchtop support for research? Very soon. For clinical support, I would guess 5 to 10 years. This will be a transformative technology for the anatomic pathology specialties for cytopathology. Next step, maturation of path informatics itself as a subspecialty. Several salient things to bring up. Building on what Dr. Friedman shared with you earlier, the toolkit. It's available for download, immediately available as of today. The intent is to be an equalizing force, to provide a metric by which you can compare disparate systems and match them to the local needs of your enterprise in a systematic and semi-quantitative ways. You can actually generate a value proposition of which system truly adds value, which system is sophisticated, which system will represent the minimum takeaways in terms of functionality that you might have now that you might lose with a more generic system. The white paper that Dr. Friedman alluded to, the functionality statements. There are many of these, and you'll notice at the bottom, they are categorized by section of the laboratory, making it easy to generate not just one value proposition, but a value proposition for each segment of the laboratory. The scenarios, which now allow a consistent scripted approach to having the vendor showcase the functionality of their system and allow for pairwise comparison of functionality through consistent and similar practice, as opposed to having apples and oranges to compare, which is a difficult cognitive process. And finally, total cost of ownership as a schedule, again, across the different laboratory systems, allowing for a numerical price proposition of the current and then anticipated projected expense of running such a system, long term, which of course is important. Another timely development in pathology informatics, which to me and to many of my informatics colleagues really underscores the fact that the subspecialty is coming of age, not just as of a valuable contribution, we've known that, but as being externally recognized, not just from pathology itself, but from all the other medical specialties as a recognized discipline and a recognized contribution. The first pool of candidates, in fact, is to be seated for the clinical informatics boards this coming October, which includes pathology. I have nothing but immense gratitude to the American Board of Pathology for taking a leadership role in identifying this as an opportunity and being one of the leaders in that group, which joins internal medicine, surgery, radiology, preventative medicine, and public health. So to be clear, pathology as a specialty is extremely interested and involved in procuring and growing the ranks of pathology informaticists. So pathologists for the first 5 years are eligible to sit for these subspecialty boards by experience, and the details are available on the ABP website. To just provide a sampling of some of the competencies, there's 4 high-level areas. Again, these can be downloaded from the ABP site that underscore the broad discipline of pathology informatics. Again, showcasing the fact it really is a distinct body of knowledge that is facilitating the practice of pathology across broad strokes of what pathologists do. Fundamentals, clinical decision support, health information systems. I mean, an LIS, in fact, is a very sophisticated health information system, if you would, which includes human factors engineering, health information systems, clinical lab standards, and then finally, leadership and management, which I would offer to you as perhaps the most important part of managing these large, complex systems. Time and time again, my colleagues and I find that the most difficult part of IT is not the IT, it's the people part. Managing relationships, managing projects, managing budgets, things outside of the actual technical layer. And in fact, this test covers the requirement of understanding those concepts. Another interesting dial of the Antikythera mechanism. 2,300 years ago, presumably, was when this machine was made. They could predict with a plus minus 30-minute accuracy when solar and lunar eclipses would take place. And they're specifically identified on this dial on a 19-year cycle. That requires a computer. This was a computer. Security. Very briefly, some comments on security. We've probably noticed in the news the last several months a lot of interesting developments. I want to point your attention to this gentleman who's actually very respected in not just healthcare IT, but across IT in terms of the topic of security, Bruce Schneier. Bruce is a conservative gentleman. When he gets angry, when he is indicating a call to arms, you know something's wrong. So we, as stewards of our information systems, are required to keep things confidential. And it turns out, curiously, that our entire fundamental internet has been compromised. The very devices at the central backbone of the internet, the switches, our PCs, probably every layer, or at least many layers of our devices, including the devices that we operate within our health systems, have multiple undocumented vulnerabilities, which means that outside parties can go in whenever they want and take any PHI they want. And I don't say this lightly because I'm, as an information scientist, very concerned about confidentiality. We have very strong evidence that we have to refactor our confidentiality systems from the ground up. And in point of fact, you will be seeing a succession of papers, for example, the Journal of Pathology Informatics, over the next several years, which will offer what hopefully will be best practices to take back the internet, to take back the ability to correctly and responsibly provide protection for the confidentiality of our patient data. And in fact, what Bruce says is a call to arms. This is just last week. To the engineers, I say this: we built the internet, and some of us have helped subvert it. Now, those of us who love liberty have to fix it. And I point this out as another area where we are actually held accountable for breaches, the breach notification rule. We have, for a larger breach, we have to publish it if it's over 499, so 500 or more. We have 60 days to publish. We have to publish our identity. If it's a clinician who lost the data, as well the identity of the health enterprise, and publish it in a prominent place. The fact that the vulnerability is from an outside third party matters not. So we have now in our health information systems tremendous vulnerabilities that we need to mitigate quickly. And so the call to arms from the healthcare and pathology informatics setting is to find the holes and plug them as quickly as possible. As a matter of fact, just yesterday, HIPAA notifications, recognizing that it would be difficult to implement various rulings. We see security postings on a regular basis, this extending the deadline. So security is an ongoing and continuous aspect of management of information systems. And finally, automation and staffing challenges. Just briefly, as a sort of photo montage of the history, We recognize this as a picture from the industrial era, maybe a laboratory from the 1940s. Automation has tremendous potential to mitigate the anticipated shortage of pathology and medical technologist staffing. And this may be of utility in at least extending the life of our ability to offer service for what will anticipatedly be a very significant growth in our volume, at least for the short term. BML, which is a current technology solution, gives an example of what the future might look like for scaled up high throughput automated labs in the US. It's an open lab topology. Instrument clusters are automation line based with robots that feed them, and in-yard robots transport things without the need for track everywhere. So a very modern, very flexible system and infinitely scalable. This is not the reality in the US now, but it might be in the not too distant future for larger settings. So this gives you an idea of the level of consolidation that is possible with automation. Over 700 analyzers on the hematology and chemistry floor. This is literally 270 meters of instruments. Even anatomic pathology has been roboticized in this laboratory with tracks for Mich histology cutting station, with barcoding used everywhere, barcoding for the cassettes, for the carriers of the slides, for the track that takes the slides to the, from the cutting stations finally to the location that reads them and then puts the final label and then distributes them for epoxy or other routine staining. Everything automated, not a single human touching them. The entire lab has 6 people running every floor. Incredible opportunities for economies of scale with that type of technology. And finally, the next disruptive wave of transformation technologies, just published 3 weeks ago in Nature Photonics, $200 in LEDs, structured lighting, a low magnification objective, and super resolution, capturing enough phase and frequency information from multiple images to exceed the data captured by a whole slide scanner, effectively turning every single microscope with a camera and these LEDs into its own whole slide scanner, which is faster and higher resolution. So we are actually witnessing the disruptive technology of whole slide scanning being disrupted by even better whole slide scanning. Time availability to market, I don't know, year, 2, 3, 4 years. This will happen, and this will transform how inexpensive and how efficient it is to manage whole slide scanning for the entire anatomic surgical pathology division. At the same time, high dimensional data analysis becoming routine. So to quote Dr. Carolyn Compton from AJCC just a week ago, we have a choice, a monumental choice. We can choose to become the steamroller of change, or we can choose to become part of the pavement. And finally, the last image of what the Antikythera mechanism looked like from the outside, the front dial and a view of the inside. Again, these gears hand ground with amazing precision to allow an individual to manually crank it and generate phenomenally precise time recordings of eclipses, the moon position, and when the Olympic Games would take place. Thank you very much.
Ladies